afternoon, everyone, and welcome to the roundtable discussion on lung cancer. It is an absolute privilege for me to be standing in for Cara Noble, who has taken ill. My name is Dorothy de Plooy. I am the service specialist at CANSA. I'm a professional nurse with 45 years experience in nursing. And the purpose of today's talk is about lung cancer. It is a topic that we need to talk about, and I'm privileged to be in the company of speakers that will be sharing their story and their journey and their experiences with us. And just to say that lung cancer is more common in South Africa. It is the third most common cancer amongst men and the fifth most common cancer amongst women. I would also like to introduce our team, Emmanuel from EP Digital, who's at the back of the house, and Lucy, our head of marketing. They are in the wings and make sure everything runs smoothly. Any questions you may have along the way, please put it in the chat box and we will answer them at the end. I think we will go immediately into the program, and I would like to introduce Shireen Rampersad, who is a lung cancer survivor. Shireen is from Richards Bay, and she was diagnosed in 2018. And in 2019, she was diagnosed with a mutation of the lung cancer with bone metastases. She describes herself as a fighter and a positive person. Thank you for being willing to share your story with us today, Shireen, and I now hand over to you. Thank you.
Greetings to one and all. Thank you very much for accepting me in this platform. I've been diagnosed with lung cancer in 2018. My symptoms all started with a severe chest pain that felt like I was having a heart attack. I had woke my husband up in the early parts of the morning and told him that I cannot manage this pain. And we rushed to the ER. On our way to the ER, I told my husband I don't want to die because this pain felt like I'm having a heart attack. On arrival at the ER, the doctor had sent me to do some x-rays. They tested me to see if I had a heart attack, and they did blood test. So when the results had come in, the doctor asked me of my family history. And in my family, we have my mom, she's late. She was diagnosed with cervical cancer. Her siblings had lung cancer, breast cancer, etc., and all passed away with cancer, terminal cancer. And he asked me to see, he referred me to another doctor called Dr. Maraj, who had come in and requested a CT scan. When he did the CT scan, he came back with the results and he told me that there's a mass and that I need to do a lobectomy. But prior to the lobectomy, I used to suffer a lot with chest pain, difficulty of breathing, and my hands used to swell up. So I was scheduled to go to Durban on the 28th of May 2018. I went to Westville Life Hospital, and there they did a bronchoscope. A bronchoscope is a tube that they insert through the throat to see your lungs. And the doctor had did the procedure, was Dr. P.S. Maraj, and he came with the results and told me that my biopsy showed negative, but he had seen there is some cancer. So he scheduled me for an operation on the 1st of June to do a lobectomy, a middle lobe lobectomy and a thoracotomy. And he had said I must notify my families because this is a major surgery. I had several doctors that had come in to do an induction on me, and they had explained the procedure of a lobectomy. And blood tests were taken, x-rays, doctors had to come and check if my heart was right, so I'd be able to be going for this procedure. The nurse had come and educated me and had told me that if this procedure doesn't work out, I will be on the ventilator and I'll be on Kimbies, and they made me sign identity forms, and I was quite scared because I had my daughter still in college, and I didn't want to die because the nurses had explained to me what is the procedure of a lobectomy. I was wheeled into theater on the 1st of June for the thoracotomy and a lobectomy. And I was put into CCU after the surgery. When I woke up, at my surroundings, I seen people crying for help. Patients were crying for help. And when I looked, I had seen this guy strapped with a belt on his chest. And he had a heart attack, and that he had a major heart surgery, and I've seen patients with the life support machines on ventilators. And that made me motivated and said, I cannot be in this position. I need to recover fast. And my doctor had I had rehabilitation where I had to learn to walk, physio, breathing exercises. And after 12 days, I was discharged, and my doctor said I had to see an oncologist. I had made an appointment with my oncologist, Dr. Smita Abrahams, who had discussed the procedure of chemo and radiation with me. She explained everything full and told me about my eating plans. And I had to recover after the operation because my wound had ended up septic. And I had to be admitted in hospital before I could start chemo. When I started chemo, I had 16 cycles of chemotherapy, 25 treatments of radiation. I didn't like radiation at all because there was a huge machine that used to radiate your body from your chest part, and I always had the fear of it. I always used to meditate and chant while I was under this machine. Chemotherapy, while doing chemotherapy, I had to have 2 blood transfusions, and chemo really made me sick. I used to vomit a lot. I didn't want to eat food, and the smells of food or any perfume triggered me. I used to be virtually sitting in the bathroom vomiting my guts out. I used to take remedies like ginger tea that used to help me with my vomiting tablets. Radiation burnt my skin. I used to have hot flushes, and I couldn't go out in the sun. I used to cover myself. After completion of my chemotherapy, the 16 cycles, I had to do a PET scan. A PET scan is a machine that you go through, and it tells you whether you're in remission or not. And at that stage, they told me that I was cured of cancer. 2019, my worst nightmare started again. I started having fatigue, breathless. I couldn't walk. And I went back to Dr. Smita Abrahams, and I told her this is what my situation is. She did a CT scan, and then she sent me for another PET scan. And in 2019, May, I was diagnosed with lung cancer that had spread to my bones. It's called EGFR, epidermal growth factor receptor. There, I had to undergo 3 times radiation. I was on Toceba, 150 milligrams tablets every day that has to be taken on an empty stomach at a set time. I had Someta drips every 3 weeks, and I had very bad side effects. Lots of vomiting, diarrhea, mouth sores, infections. I couldn't go out in the sun. My hair had changed. It had a different appearance. My skull was full of sores that I had to use special Colobex shampoo that used to soothe the sores. Mouth infections. I had mouthwashes. My daughter had to take a gap year in her studies to look after me. She used to do the day shift, and my husband, Shamil, used to do the night shift. I used to miss myself bad. And during COVID time, my husband had renal cancer, and he had to go for operation. And while he was being operated, I had to go for my treatment, and I didn't have that support to give him, like how my family had supported me during my treatment of cancer. And family support is one of the things that you need during cancer treatment. And there was lots of complications with me during my cancer treatment. I used to get irritated with my family members. I couldn't eat food. My husband used to make special meals and he used to put it down my throat. No matter how much you vomit, you must always eat, because that gives you the energy to be strong and you can fight your disease. And cancer is where you have your good days and your bad days. And for me, I had really bad days. I couldn't manage. I used to get frustrated with myself because I couldn't eat certain foods. Until now, with Tasiva, there's side effects that changes every time. And you have to be on this medication every day of your life. I wish that one day I could be cured from lung cancer and lead a healthy life like everybody normal. And it's really difficult to be in this situation with lung cancer because you cannot breathe sometimes. You're always with pain, your bones pain constantly. There's not a day that you're without pain. And you're always on painkillers that help you to relieve the pain for that moment. And always listen to your oncologist. I had a very good oncologist, Dr. Smita Abrahams, who gave me advice. And she also saw me 24/7, should I be in a difficult situation. Her advice was eat correct. And she always followed on us. She's a very caring doctor. To people who have cancer, I say, be positive and don't listen to negative stories, because people are easily there to influence you and say, stop doing your treatment. And I cannot go out too long in the sun. I have to use special products, unscented perfumes. And these are the medication that I take. This is Tasiva. It's a tablet that has to be taken every time. And my cancer is not curable. One day I wish to be cured. Thank you.
Wow, Shireen, wow. Listening to your story, it just makes the cancer journey so real, you know. It's very rarely that we see a lung cancer survivor, because you are really a survivor, having shared all that you went through. And something that stood out for me is when you said, when you go into the tunnel, the claustrophobic feeling, because that is what the cancer patient says. You know, when they go into that round machine, it feels that everyone I've spoken to has said the same thing. And you're also saying it, you get that feeling of claustrophobia because you're in this closed and you can't run anywhere, you just gotta wait it out. So thank you for your being brave enough to come on and tell us your story, and also for fighting it, and also then having your husband diagnosed while you are fighting the battle. It's and then having your wound turn septic. I think it's like a double whammy, because you have lung cancer, your radiation is burning your skin, and then your wound turns septic, and then you ask yourself, okay, what else can go wrong? You know? So thank you for that, really, from my side and from everyone, I think, that listened to your story. Thank you for giving us a perspective from the life of a lung cancer patient. And it sounds like you were really surrounded with a wonderful team of oncologists, and that makes all the difference. And lastly, I just want to end off with what you said was family support is critical during the cancer journey. Thank you.
Thank you.
It is now my privilege to introduce someone that I had the privilege of knowing during a time at CANSA, Krista Mathieu. Krista is a lung cancer patient caregiver. In 2002, Krista joined CANSA as a fundraiser and assisted with patient care in Krugersdorp. She then moved on to greater things, but has always been part of the cancer family. Her dad was diagnosed with lung cancer and sadly lost his battle on the 12th of August 2021. Her mom was diagnosed in March with colorectal cancer and has recently been told she's in remission. Krista says that being a caregiver is such an honor, but it is hard and the reality is cruel. She believes that every day is a blessing and is definitely not a given. She shares with us her journey and the impact it had on her family. Just to also note that Krista was supposed to join us on our last webinar, but her dad fell ill and she pulled out of the morning of the webinar, and her dad passed on 4 days later. Krista, we are so happy that you are brave enough to join us today, and we really look forward to your journey as a caregiver and that you are able to share it with the audience. Thank you.
Well, thanks, Dorothy, and thank you everyone for the opportunity. I promised I won't cry, and I'm really going to do this, trying to keep everything intact. So, Dad was diagnosed in 2016. And the one thing that I learned from the Cancer Association is when you get diagnosed, you don't do this alone. Whether you've got friends, family, or cancer behind you, someone's always going to be there. And those who don't want to see the battle or those who don't want to be part of it, that's their choice. But when Dad, and funny, Shireen, when what you were saying, Dad had the same. We thought he was having another heart attack. He drove himself to the hospital. He got there, they admitted him, they did the checks, and then we found out lung cancer. And it came as a shock. And we were scared. But the one thing I turned around straight away and I said is, we're doing this together. And that's the one thing I'm most grateful for, because we saw so many people in the Cancer Association where caregivers weren't available or weren't willing to go through the path that the patient had to travel. And when Dad got diagnosed, I sat down with my mom and my sister, my husband, and I said, you know what, we're doing this as a family. We're not letting Dad run this path by himself. So I see Olivia's on here. Anjuline used to work for the Cancer Association as well, a very good friend of mine, a nursing sister. And every time I got Dad's report, I went straight to Anjuline and I would give her stuff and say, explain to me what this means. And by the time we went to see the oncologist, she came with a very rosy story. You know, you've got lung cancer. We're going to try and assist you. This is the treatment. Don't forget, these are the negative effects, but this could be the positives. And I turned around and I looked at her and I said, you know what, we're not here for a rosy story. We're here as a family to hear the bad side of it. The good is amazing, but we need to know the negatives, because I need to be able to support Dad in the negatives. If he's nauseous, what do? Don't tell him, oh, you might have nausea. Say to him, you are going to lose your hair. If not, that's a bonus. You are going to be nauseous. If not, that's a bonus. But this is how we're going to treat it, and this is what we're going to do. So Dad started treatment in 2016. He had the same fear for that tunnel. Dad is claustrophobic. He hated small spaces. So they had to give him calming meds to actually get him to go in for the scans. It was not something he would just do. And every time we would check in at the hospital, people would say to him, good luck, how's it? What was the outcome? And he would always be positive. And he would turn around and say, oh, I've got another guarantee on life. I'm back next week for my next chemo treatment. And I think the most important thing was that at that stage, they weren't living with us. So Dad and them lived in Pretoria. My sister lived in Pretoria, and we stayed in Krugersdorp. And what we did is every day that Dad had chemo, we would drive down to midstream and meet up and sit with him throughout the entire chemo session and then go home. Dad was never alone. The only time he had to do his treatments by himself was when COVID hit and we weren't allowed in. And that was most probably for me as a caregiver and my family, one of the worst things we had to go through, because in that time we would be outside in the parking lot, wondering how he's doing, or has he gone in for treatment yet? Is he almost done? Where is his position at? What is the doctor telling him? All of that. And we had no control because we would be sitting in the car waiting for him to come out. And last year in May, Dad got really sick. He was on cisplat, which the nurses could help me, but I think it's a platinum-based chemo. And it made him really sick. And we were ready to bury him. He stopped eating for 3 weeks. He cancelled his very last chemo treatment. And I sat with him the day and I said to him, Dad, you've got one treatment left. Is this really the way you want to do this? And he looked at me and he said, this is the one time I don't have the energy to go. And we cancelled it. And we lived with that and we were happy. And he decided that day that he's going to live every single moment to the fullest. With that, by that time, they were living with us. My kids were Dad's everything. Dad was ours. And the last year's journey, we saw him picking up weight and we saw him losing weight. We saw him not eating for 2 weeks, living on fluids. And then we saw him eating more than we could all eat as a family. We were supposed to go to the beach in April this year. It was going to be our last. We knew time was slow and time wasn't where we wanted it to be. So we were going to do a final trip to the beach. And then my mom got diagnosed in March. So we had to put everything on hold. And little did we know that Dad had a group called the Kick the Bucket group. It was all the old friends from matric. And he had actually sent them a letter saying that he's on borrowed time and that everything he's going through now is literally just borrowed. We postponed the trip to the beach. We are doing everything, but he made the following mile baller. Sorry, I'm not sure what the English is, but he sort of set goals for himself to reach. And he would turn around and say, I made it to our wedding anniversary. I made another Christmas. He called my mom the witch, and he would say, I made it to the witch birthday in Jan. And then my sister and I would say, he said he made it to March, but we never knew about this letter. And in this letter, he said that we're supposed to be going to the beach in November, but he's not going to go with. So he knew. And as a caregiver, we try and get so much info out of our parents or out of the person you're looking for. And yet they tend to be strong and they tend to hide a lot. So I went at our last Father's Day and I gave Dad a book. It was actually last year, a notebook. And I said to him, write how you feel, write stories and share your journey with us because you're not a talkative person, but let me see how you feel. And the day he passed away, I went and I looked for that book and it was empty. And all we wanted was to know. But through the letter he wrote to his friends, we knew as a family he was happy. We knew as a family he was ready. And we knew that when the time comes, he'll be where he needs to be. And on the 10th of August, I phoned Olivia from CANSA and I said to her, we're struggling, Dad's battling to breathe, please help. And she came through and Dad had an oxygen level of 37. We managed to get him oxygen and we sat with him, and even through that, he was still joking. But the one thing I can tell you that meant more to him than anything else was he was home and he had me, he had my sister came through from Pretoria, my kids were there, everyone was with him. And you will never know how much that means to someone until you get into that position where you can see he's tired, but he's where he wants to be and he's at peace. And that evening, the kids came in and they said goodnight. Dad was still making jokes with Mom and my husband. I was trying to arrange another day of work. We literally sat with him, Mom and myself, for 2 days. We did not sleep. And then 2 o'clock on the 12th of August, Dad passed. And it was an honor. It was the biggest honor to help him, to walk this journey with him, and to be there through the good and the bad. And everyone that's scared to go into a journey of caregiving, don't be, because the gratitude in their eyes and what it means is worth more than anything anyone can give you. So as a caregiver, I said, with Mom being in remission, very grateful, but if she needs me, I'll be there. And always keep in mind that up until the end, they want to be with family. They don't want to be stuck somewhere in a room by themselves. And if you can give that to your family member, their gratitude will be in their face right until the end.
Wow, Krista. Wow. You're a very brave soul to come and share your father's journey and you being the caregiver. I think families struggle with caregiving sometimes because of having to deal with, to see the person they love go through what you just described your dad went through. It's not an easy journey. And we salute you for that. And I see Olivia did put in the chat box that your dad loved you very much. And you should know that. And I think what stands out for me is the fact that you said you went with your dad to his chemotherapy, because that's a lonely place for the patient to be when they are having to receive chemo. Sometimes the only support they have is the other chemo patients in the room with them. But we also try and get a family member to go with a cancer patient to the doctor to ask all the questions that you said that Anulin, who was one of our nursing sisters, had briefed you on and had told you what to ask the oncologist, because there's a lot of big words that are said, Dr. Govender, no offense, but you know, the medical terms is the medical terms. But sometimes when you're the patient, you feel overwhelmed and you need another person to be able to listen and to ask the questions. And so thank you for sharing your journey. And I'm so happy to hear that your mom is in remission, and so good to see you again today. Thank you. I now have the privilege of introducing Dr. Pavan Govender. Dr. Govender completed his Masters of Medicine in Radiotherapy and Oncology through the University of KwaZulu-Natal in 2011. He then received his certification as an oncologist from the European Society of Medical Oncology in 2012. After stints as the clinical head of oncology at Nkosi Albert Luthuli Central Hospital in Durban, and acting head of department in the Department of Radiotherapy and Oncology at the University of KwaZulu-Natal, he ventured into private practice in October 2016. Joining the OncoCare team, Dr. Govender is on the editorial committee for the South African Journal of Oncology and serves as a postgraduate examiner with the College of Radiation Oncologists. He is also on the executive committee of the South African Society of Clinical and Radiation Oncologists, SASCRO. To date, he has had 14 publications in peer-reviewed journals. He enjoys reading, music, and yoga in his spare time. Dr. Govender will focus on the signs and symptoms of lung cancer, the challenges of early diagnosis in South Africa, treatment options, and advice for lung cancer patients and the COVID-19 vaccine. Thank you, Dr. Govender. I'll hand over to you now.
Thank you to CANSA for affording me the privilege of being here today. It was quite amazing listening to those very heartfelt stories from the previous two speakers. I can relate a lot to those stories. It's something we encounter on a day-to-day basis. And perhaps we can chat about that in more detail towards the latter part of my talk. From my side, look, I started off in oncology in 2004. Lung cancer is undoubtedly one of the commonest cancers we encounter on a daily basis. Our chairperson mentioned that it's the second commonest cancer in South Africa, but it's also one of the highest causes of cancer mortality in the world. So that's important to bear in mind. What's been very reassuring for me as a practicing oncologist is the fact that we've made significant evolutions in terms of treatments for lung cancer. Let's start off with the broad understanding of lung cancer. Lung cancer can be distinguished into two broad headings or subcategories. One is your non-small cell lung cancer, which accounts for about 80% of cases. And then you get the more aggressive variant called small cell lung cancer, which accounts for 20% of cases. Patients usually would present with symptoms such as a persistent cough. Sometimes you might find blood in the sputum, unexplained weight loss, chest pains, shortness of breath. So very commonly we encounter respiratory symptoms along with things like loss of weight and loss of appetite. And that's what usually prompts people to seek medical attention. And invariably when patients present with these symptoms and a diagnosis of lung cancer is made, unfortunately it's usually in the more advanced stages. And hence, august bodies overseas have now recommended that we embark upon lung cancer screening. The US Preventative Task Force has now advocated for screening for patients with lung cancer, especially those with a 20-pack year smoking history. So that basically means people who have smoked 21 pack of cigarettes per day for at least 20 years, and patients who are between the ages of 50 to 80, and patients who are either currently smoking or have not quit for more than 15 years. And they recommend low-dose CT scans as part of screening for those patients. In South Africa, we haven't really taken that on board just yet, but it's certainly something to look at given the fact that 70% of lung cancers are invariably diagnosed at an advanced stage. So if you want to start detecting lung cancer at a much earlier age, screening is really, really pivotal to help us give our patients a better prognosis. So when patients present with these symptoms, they would invariably see their general practitioner. And sometimes we would start off with a basic investigation like a chest X-ray. If the chest X-ray shows an abnormality, then we would normally proceed to doing a more detailed investigation like a CT scan. And if we find a mass in the lung, then we would often undertake a tissue diagnosis in the form of a biopsy. Once the biopsy confirms lung cancer, we try and work out what type of lung cancer we're dealing with. A concept in oncology we refer to as the histology of the lung cancer. Is it a non-small cell? Is it a small cell? And once we've worked that out, then we would do something called staging. Staging means to assess how far the cancer has spread. And our first speaker, Shireen, mentioned that she had a PET scan done. So a PET scan is undoubtedly one of the Rolls Royce of staging investigations. It's a very sensitive investigation. It allows for very good detection rates of spread of cancer outside of the lung. And it certainly gives us a better understanding of the stage of disease. Based on the stage of disease, we can then decide whether the cancer is amenable for surgery or not. As I mentioned, in most cases, 70% of cases, when it's detected at an advanced stage, those cases are outside the realm of surgery. And that's when we talk about systemic therapies. And there are quite a lot of systemic therapy options that have come to the fore. Historically, as I mentioned, when I first started off in oncology, the backbone of treatment was chemotherapy, and it's what we call platinum-based chemotherapy. And using platinum-based chemotherapy we looked at a median overall survival of approximately 12 months for patients with stage 4 non-small cell lung cancer. We've thankfully come a long way from those days. We all know that the oncologists that treated patients back in the early 2000s would testify that the toxicities of chemotherapy were quite challenging to endure, and more especially, the benefits with chemotherapy were modest at best. We've since moved on, and Shireen's given us an account of mutational testing for non-small cell lung cancer. She describes having what we call an EGFR mutation, which is approximately 15% of non-small cell lung cancers. So that is what we do. Once we find a patient diagnosed with advanced non-small cell lung cancer, we now try and work out what the subtype of lung cancer we're dealing with is. It's no longer a case of everyone being dished out with chemotherapy. In fact, chemotherapy is largely relegated for a very select group of patients. First of all, we'll try to ascertain if the lung cancer has a specific mutation, like the EGFR mutation. We also test for another biomarker called PD-L1 to assess whether patients may be eligible for immunotherapy. So these are the kind of things we're looking at, where we're looking at a more one-size-fits-all approach, as opposed to days gone by, where it was chemotherapy for all patients with advanced non-small cell lung cancer. And that allows for us to improve our survival rates. I mean, Shireen's is proof of the pudding that with using these new targeted therapies for mutations, we can certainly help improve survival rates. And likewise, for patients that do not harbor mutations, but who have a high expression of PD-L1, they have very good outcomes with the advent of immunotherapy. Immunotherapy is treatments that helps to supercharge the body's immune system and help us to fight off the cancer cells. And using immunotherapy, targeted therapy, we have now managed to stretch the survival rates for patients with stage 4 lung cancer from early days in the early 2000s to an average lifespan of about 12 months. We're now looking at an average lifespan of approximately 3 years. So we've made significant inroads in terms of helping improve the prognosis, even for patients with advanced non-small cell lung cancer. One of the other aspects that was asked to focus on is to look at the role of COVID vaccination for patients with lung cancer. I think we've employed a blanket philosophy for all of our patients with a diagnosis of cancer. We've strongly advocated vaccination for all patients with cancer, whether patients are on treatment or off treatment. By virtue of having cancer, they are at a slightly higher risk of complications with COVID-19, and therefore we think it's critical for all patients with a diagnosis of cancer to have the COVID vaccination done. So yeah, I think the important facets are obviously looking at prevention, what we can do to diagnose cancer at an earlier stage. Do we now go upon embracing the Americans' directive to start doing lung cancer screening? Do we have capacity, both in the private and state sectors, to embark upon screening for patients with a strong smoking history? The second fundamental aspect is staging. So once patients are diagnosed with lung cancer, being sure that we know what the exact stage is, because the treatment paths vary quite considerably depending on the stage of diagnosis. And as we know, as we go from stage 1 up to stage 4, the prognosis is quite variable as well. For patients, stage 1, stage 2, the treatment is definitely with curative intent. Stage 3 is associated with a very high relapse rate. And stage 4, unfortunately, is incurable. And the primary role of treatment there is improvement of quality of life and improving overall survival. One of the big gaps that I found when I worked in the state sector and then transitioned to the private sector is that a lot of these newer treatments are unavailable in the state sector. And we know that only approximately 8% of our patients have access to private healthcare. So we've got to think about how best to ensure that the 92% of patients that are using the state healthcare facilities can also enjoy these new cutting-edge treatments like immunotherapy, like targeted therapies. And that's something where the advocacy groups like CANSA has a very strong role to help us to improve accessibility to these newer treatments. I'm going to stop there now, but look, I'm going to be around. So if you guys have any questions, just to touch base on Krista, I think one of the important points that came out of her discussion was, you know, family support for patients that are undergoing cancer treatments. One of the big voids in our healthcare system, both in the private and state care systems, is the fact that we don't have enough palliative care doctors. Within the context of COVID-19, a lot of the hospices shut up shop, and we're not helping with convalescence care for patients with pre-terminal disease. And that's where the idea of caregiving really needs to focus on. You know, family members. I mean, Krista is testimony to the important role that we can all play in terms of adding dignity for patients when they reach those last legs of the cancer journey. Never an easy journey for the family. I know that from personal experience, it was very, very challenging for those family members who didn't have access to visiting loved ones with advanced cancer. And it was very challenging. You know, the patients had restricted access to their family, and sometimes just a gentle holding of the hand or a hug. You don't quite enjoy that when you're sitting in an institution like the hospitals. Another reality which is uniquely South African is the fact that there's a high immigration rate. I mean, a lot of our patients who are elderly and diagnosed with lung cancer often come in and they have to charter this journey without a lot of family support. You know, a lot of their family members are overseas. And I can tell you now, it's an especially difficult scenario when you have to navigate a journey like cancer, undergoing the treatments and the dastardly side effects single-handedly. So we really need to focus on how we as a community can try and help our patients charter this journey with more support, more family support, more caregivers. One of the unique offerings by Discovery Healthcare is that they have something called an advanced illness benefit, which helps patients access palliative care doctors, hospice, 24-hour caregivers. I think the reality is that a lot of us are working. You know, we can't spend 24 hours a day with loved ones. We've got to put food on the table, so we can't really take an indefinite time away from work. So, you know, we have to look at tailor-making packages to allow patients and family members to ensure that we can preserve quality of life, ensure that all the emotional needs of not just the patient, but the family members themselves are also looked after. And I think that's where we need to individualize treatment options, make sure that the family and the patient are afforded the dignity and the quality of life that they deserve. Thank you.
Thank you, Dr. Govender, for that reality check of the reality of the cancer patient, and specifically the lung cancer patient, and what we as a community have to think about when it comes to holistic care for the patient. And I also think that I'm sure it must have been even worse during the COVID-19 pandemic, which we are in, because there was also a need for oxygen there. And then the lung cancer patients needing oxygen, the COVID-19 patient needing oxygen. And I mean, it's well known that at some stage hospitals ran out of oxygen. So yeah, I think the lung cancer patients, and this question that's going to be coming your way, that is going to be asking about the survival rate for lung cancer. I think that was one of the questions. And maybe at the end, after our next presenter, we will deal with all of that. But thank you. Thank you for an eye-opener around what in the first world countries they are doing about early screening with CT scans, and we are not there yet. But I think if we can just get to a place in South Africa where we have good quality of life for the cancer patients and pain and symptom relief, etc. But I think our next presenter will be addressing that. Thank you. It now is my privilege to introduce a colleague, Zodwa Sithole, who is CANSA's Head of Advocacy. Zodwa is formally trained as a general nurse, midwife, primary health care, nursing administration and education, community health care, and palliative care. She holds a BCom degree and a master's degree in nursing. Zodwa has participated in numerous national and international conferences. She has managed to advocate for the integration of palliative care in the caring of inmates living with life-threatening illnesses in the South African prisons. She has also advocated for palliative care with traditional healers, which resulted in the development of a palliative care curriculum for traditional healers. She coordinated the development of Alliances for Access to Patient Care, a group of individuals who are not working for palliative care but assist in advocating for palliative care. She's currently working for the Cancer Association of South Africa, which is our organization. And so, Zodwa, I'm going to be asking you some questions. And I think the first question would be, how would you define palliative care?
Thank you, Dorothy, for that introduction. I've got a very poor connection. Can I please close my camera, please? Thank you, Dorothy. But before I answer your question, I really want to say thank you to Krista and Sharon for sharing their stories. You can see how important is palliative care. Also want to make it clear that palliative care is the part of cancer treatment. It needs to be there. And doctor, also, I just want to mention that one of the things we are advocating for is the training of the doctors on palliative care and the provision and the professional nurses. So it's so important for us. So Dorothy, to come back to your question, I want to say, when you are living with lung cancer, both the disease and the treatment for it can take a toll on your quality of life. You may need an extra help. With it comes to manage your severe pain, nausea, fatigue, depression, and other symptoms. This is where palliative care comes in. It can be, ease those symptoms. But unfortunately, people, they think that palliative care is only for the end of life care. So to define palliative care in a nutshell, what do we mean by palliative care? Palliative care is the relief of suffering. The things I was just mentioning above, pain, nausea, fatigue, depression, cough, whatever the patient is presenting with. Palliative care is the response to the needs of individual person with life-threatening illness and to the families. So for palliative care, it's so important to include the family. You heard what Krista was sharing. Sometimes you find that the patient is okay, but the family, they're really struggling to accept that my mom, my dad, my sister is really having this life-threatening illnesses. And again, palliative care can be used at any stage of lung cancer to improve the quality of life. Rather, it is about living. It's not about giving up hope. It is about living as fully and comfortable as positive, And it is provided by the team, multidisciplinary team who's treating the patient, the social worker, psychologist, spiritual counselor. So those are the people who are providing the palliative care. Thanks, Dorothy. Hello? Hello? Hello?
Thank you. Sorry, Zodwa. Yes, thank you. I was just struggling to unmute myself. Zodwa, when is the right time to introduce palliative care?
Thank you, Dorothy. Palliative care should be introduced when a patient is diagnosed with life-threatening illness. It's not about end-of-life care. Really, we are advocating, that's why we are advocating for the doctors to be trained on palliative care, so that when they're treating those patients like lung cancer, palliative care start at the beginning. Pain is not that, I know, Dr. Governor, I just want to say, we always say that if patient present with pain, that pain can be managed if it's prescribed at the right dose at the right time. So we don't want to say it's okay to have pain because we've got cancer. We are always saying that palliative care, the pain can be managed, and morphine, it's so cheap, it's not an expensive drug. Thank you, Dorothy.
Zodwa, thank you for that. My last question I'm going to link the two is, tell us a little about palliative care as a human right, and does South Africa have a palliative care policy?
Okay, thanks. Palliative care is a fundamental to health and human dignity, and it's a basic human right, Dorothy. Palliative care is highly effective in managing pain and physical symptoms and can improve adherence to medication. So it is really human right. Nobody should suffer in pain. I always say to the patient, if you go to your doctor, you must tell your doctor that, doctor, the medication you are giving me is not helping me to manage my pain. So it is your human right. You really need to, I don't know whether the word demand, but it needs to be managed. So speak to your doctor about the pain. So coming to the policy, Dorothy, I was the part of the team who advocated for palliative care policy. I was on the team who developed the palliative care policy. So it was approved in 2017. Unfortunately, it's not being implemented in all the provinces. Actually, I would say very few provinces. And the Department of Health has contracted a palliative care coordinator who's trying to implement, to make sure that the policy is being implemented. And unfortunately, Dorothy, I must mention that that person is on the, what do you call it? It's on the contract, and the contract is coming to an end of December. So I don't know, we need still to advocate for palliative care and to make sure that it is implemented. The policy is there, it needs to be implemented. It needs to filter down from the national down to the provinces. Thank you.
Thank you, Zodwa, and knowing you and your push for advocacy, advocating for palliative care, I'm sure it's very high on your agenda to ensure that that post is filled exponentially, and so that palliative care remains a high on the agenda of policymakers. I now wish to thank all the speakers. Thank you so much for your time and for sharing on this platform. And Lucy, are there any questions in the chat box?
None that we can see, Dorothy. Thank you very much.
Thank you. I think one of the questions, just before I end off, a question that came through Dr. Govender was, can you function with one lung?
Yes, of course you can. A lot of patients with disease that is involving more than one of the lobes of the lung will require what we call a pneumonectomy. And I think that speaks to the fact about how resilient an organ the lung is. And that also kind of helps one understand why so many patients with lung cancer often present in the advanced stages. The lung mass has to get to quite a substantial size before it starts manifesting with symptoms. And that is why invariably a lot of patients will have advanced disease on presentation. The lungs are such a fantastic organ. So the long and the short is, yes, you can definitely survive with one lung. And there are a lot of our patients who are working, living full lives with only one lung.
Thank you. you. And I just have one comment on your presentation is, they really, how prevalent is the fact of someone smoking 21 packets of cigarettes per day? Because that would be one packet every hour almost.
Look, I think it's still a reality. Hopefully in the modern era, now that people are more au fait with healthy living, that's less of an issue. But again, remember, most people who are diagnosed with lung cancer present over the age of 50. And in that generation, smoking was still considered very fashionable. So as I said, hopefully now that there's a bigger buzz around healthy living, curtailing one's consumption of processed foods, exercising, quitting cigarette smoking altogether, reduction in the consumption of alcohol. And I think that's where it kind of starts. We're speaking about lung cancer screening, but it even goes back before that as well, where we all got to focus on making sure we lead healthy lifestyles. And I think that's what we got to do. I mean, if we have a loved one who's smoking, we've got to be forceful and say, hey, hold on, you've got to value your life, because cigarette smoking is not just a risk factor for lung cancer, but a lot of the other cancers in the human body, like head and neck cancer, bladder cancer. So, if you love your loved one enough, that's where we're going to start becoming more firm about getting them to stop smoking. And now there's lots of tools, drug remedies to help patients to stop smoking as well. So it's never too late, right? As I said, if you can stop smoking for 15 years, then you're certainly going to lower your risk profile for lung cancer.
Thank you, Dr. Govender. Zodwa, you got your hand up.
Govender, I've heard people saying that I've never smoked in my life, and quite a few of those people to say I've never smoked in my life, but now I've got lung cancer. So maybe do we have a percentage of, people who haven't smoked and people who have smoked in terms of lung cancer? Can you just share that with us, please?
Dr. Govender, are you able to respond to Zodwa's question?
Hi, sorry about that. I was just taking a phone call. Yeah, look, there is certainly a cohort of patients that don't smoke, who are young, female adenocarcinoma, who do, sorry, my phone's misbehaving. I'm just going to switch it off. Yeah, so there's certainly a cohort of patients, but an uncommon percentage. 90% of lung cancer patients, the commonest risk factor is tobacco smoking. So there's a very small 10% population who are non-smokers. And we have a phenotype of patient, female adenocarcinoma, non-smoker, usually of Asian origin, that tend to harbor these mutations that Shireen spoke about earlier on. So if we see that category of patient, those are certainly the category of patient where we will do reflex testing. We will certainly look for mutations. And most often than not, we will identify mutations that we can utilize targeted therapy for.
Thank you.
Thank you, Dr. Govender. I'm going to now end off this session, the webinar, by just saying thank you for Novartis. Thank you for giving lung cancer a platform to be heard and to give more patients and family members access to education and hope. I wish to once again thank all the speakers and for all the attendees. Shireen, you've got your hand up.
Yes. So I would like to ask if it stops working. What's the next solution?
Sorry, I think we battled to hear you there. If you could just repeat your question.
I would like to ask Dr. Govender, what happens when target therapy stops working? What is the next solution for lung cancer patients?
So if you're referring to your scenario, Shireen, are you talking specifically with regards to your scenario
Yes,
where you've got an EGFR mutation?
yes.
Right. So for patients that progress on erlotinib or Tarceva as you know it, we would usually do a repeat biopsy if you start developing disease progression on the erlotinib or Tarceva. That the most common resistance mutation is something called a T790 mutation. If that biopsy shows a T790 mutation, then you will be eligible for a drug called osimertinib or Tagrisso.
Thank you.
Okay, Shireen, does that answer your question?
Yes, thank you very much, Doctor.
Okay, thank you,
Pleasure.
everyone. Thank you, everyone, and thank you to Emmanuel and to Lucy, who's been behind the scenes and keeping everything together. Thank you so much for the support, and thank you, and have a good afternoon. Thank you.